Alright guys, let's talk about lumbar muscle strains. If you hear any weird noises, I'm trying to distract a crazy kitten right now, so that might happen. Alright, back to it. So, lumbar muscle strains. These are occurring when you are going outside of your normal range of motion for that muscle, or if you're having an excessive force output from the muscle that's surrounding or supporting the lumbar spine. Really, these can happen in anybody, female, male, but most injuries do happen in adults aged 20 to 65 years. Adolescent and early adult athletes do have a pretty high prevalence of getting lumbar muscle strains. So some outcome tools you can use before they even step foot in your clinic include the modified Oswestry's Low Back Pain Disability Questionnaire and the Roland-Morris Disability Questionnaire. So aggravating factors, this is going to include active movement in the direction of that muscle. So for my example throughout this entire presentation, we're going to use an erector spinae muscle strain. So doing extension is going to be painful. Passive stretching into the opposite direction, so flexion in this case, or a prolonged position of stretch, so again, flexion. Easing factors are going to be positions of comfort, whether that's sitting, standing, walking, laying down, rest, ice, and heat. So a 24-hour pattern might look like they're going to have stiffness in the morning, but it's going to get better throughout the day with some movement. However, if they're doing too much throughout the day, that pain might exacerbate and then it won't subside until they rest. So differential diagnosis is really important. We learned that a lot of things refer to the low back. So it's definitely important to do a systems review and a review of systems if you feel that it's appropriate. This can be done either before the examination or after the examination. I think it's important to ask some specific GI and bowel and bladder questions. So differential diagnosis might include renal dysfunction, colorectal cancer, AAA, metastasis, or ankylosing spondylitis. So some signs and symptoms indicating referral to a physician would include pain that's lasting longer than 10 to 14 days, unexplained weight loss, pain at night or at rest, severe abdominal pain, an unexplained fever greater than 100.4 degrees Fahrenheit, or bladder and bowel incontinence. So now moving on to the exam, just some precautions and contraindications before you start. Be careful when applying resistance during the exam, as this might elicit a very strong pain response. Do not apply thermomodalities until 1 to 2 days after the injury has occurred, and avoid bed rest. We definitely want to just keep these patients up and moving. It's going to help with healing. So now moving on to the physical exam, our active movement testing, again, using the example of an erector spinae strain. It's going to be painful and limited in the direction of the action of that muscle, so extension. Passive movement testing, it's going to be painful and or limited in the opposite direction of that muscle, so flexion. Resisted testing. If you are having a patient go into extension and then you're applying a resistance into flexion, that's going to be painful or limited in the case of an erector spinae strain. So with accessory motion testing, we learned that PIVMs and PAVMs are used primarily to assess the mobility of the vertebrae, but you may actually elicit a positive finding by exacerbating the pain that's caused by that strain. Neurodynamic testing is not very important, and it's not going to really be helpful in identifying a lumbar muscle strain. And then two good special tests to use in this case would be the prone instability test and the passive lumbar extension test. These both are going to look for inefficient stabilization of the lumbar segment. So the prone instability test has a sensitivity of 61%, a specificity of 57%, and a likelihood ratio of positive 1.41 or negative 0.69. The passive lumbar extension test has a sensitivity of 84.2%, a specificity of 90.4%, and a likelihood ratio of positive 8.84. Palpation findings. Your patient's going to be tender to palpation on that specific soft tissue that's strained. So the erector spinae are probably going to elicit some pain for that patient once you palpate them. You may also find trigger points, the inability to roll the skin over the lumbar spine, and possibly asymmetries in the lumbar vertebrae. Diagnostic testing or diagnostic imaging is not necessarily indicated unless the pain has lasted for more than 6 weeks and they're not improving following an appropriate course of physical therapy. So they may get a radiograph or an MRI done in that case. There's no true gold standard. Surgery is also not typically indicated unless they figured out that there's both contractile and inert structures that are involved.